Okay, so I think we're ready to get started. I'm really looking forward to this discussion. My name is Joshua Sharfstein. I'm co-chair of the Roundtable on Population Health. I want to just start by thanking the staff of the Roundtable, Alina Basiu, Carla Alvarado, and Kimani Hamilton-Ray for their work putting this together. And now we're going to talk. It's been such an interesting conference so far, and I've learned a great deal about the challenges that we're facing, how to go about thinking about solving them. But we're going to talk to three people whose job it is to solve them. And three terrific people. I'll introduce them. We're going to have a conversation about finding common ground to move population health forward. And immediately to my right is Dr. Joneigh Khaldun. She is the Commissioner of Health for the City of Detroit. She is an emergency room physician. She formerly was the Chief Medical Officer for the Baltimore City Health Department. I can say with direct experience that after she gives a lecture at a public health school, she is mobbed like a rock star. And one fact about Joneigh you may not know is her very first job was to ride on helicopters with transplant surgeons. So she gives you a little sense of her fearlessness in tackling a whole bunch of different issues. And then immediately to her right is Ellen Marie Whelan. She is the Chief Population Health Officer at Medicaid and inside CMS. She formerly worked at the Innovation Center at CMS. She's had many other jobs. She's a pediatric nurse practitioner and started a clinic in West Philadelphia. I know her from her time on Capitol Hill, when she was incredibly involved in a number of really important health policy issues. And then to her right is Dr. Rahul Gupta, who is the Commissioner of Health for the state of West Virginia. He is an internist. I'll tell you, he's not only the Commissioner of Health, but he was the President of the Medical Society in West Virginia, which is an incredible combination, gives you a sense of his political skills. When I was the Secretary of Health in Maryland, they had a name for me at the Medical Society, but it was not president. He was able to do both things, which I'm very impressed, and he is going to be taking a new role soon as the Chief Medical Officer and Senior Vice President at the March of Dimes. So in this discussion about finding common ground, I think we'll go city, state, federal to get some opening comments out, then we'll have a conversation, and then we'll reach out for questions. So my first question is to Dr. Khaldun, the Detroit, as you so ably told our public health school when you came and spoke, Detroit faces many different public health challenges. You are thinking not just about vaccination campaigns, but a lot of the roots of those public health challenges and the history. And you've taken over a health department that just a few years ago didn't exist. So in order to make progress, you're building your health department, you're building awareness of these problems. How do you go about searching for common ground to gain momentum for the great work you're doing?
So thank you. Thank you, Josh. Great question. So yes, I am the Detroit Health Commissioner, and there have been probably more than 5 health commissioners in Detroit over the past 10 years or so. So there's been a lot of transition in public health and in city government, quite frankly, in the city. So what I've really focused on in my role, and I've been the health director for almost 2 years now in Detroit, I've really focused on thinking about this public health ecosystem. It is not my role to come in and save the day for public health in the city, right? There's a lot of folks, a lot of amazing folks, some of which are in this room. Dr. Phyllis Meadows, actually, was one of the commissioners in Detroit previously. There's a lot of great momentum in the city. What I've done is thought about, okay, who are all these players in the ecosystem? Of course, there's hospitals, but there's also police, there's schools, there's EMS. What are the gaps? What are their strengths? And then what are their needs? And so instead of coming in and launching a one-off Detroit Health Department program, I focused on bringing folks together, identifying gaps, and where appropriate, filling those gaps with the health department, but also aligning folks around common goals.
Great. What about as you're trying to get regional or state forces kind of engaged in your work or supportive of your work? What kinds of, what's that challenge and where do you see potential for progress?
It is challenging. Michigan is a very diverse state. Detroit does not look like much of the rest of the state. I don't know if you've ever been to the UP, but Michigan has a very diverse population. However, what happens in Detroit has a significant impact on the overall outcomes for the entire state. So I've actually used that, and I have wonderful state colleagues as well, to really help them understand that if you come and pay attention to Detroit, you're really going to be helping the region and the state as well.
Great. I want to turn to Dr. Gupta. West Virginia has the highest rate of opioid overdose in the country by quite a bit. You have had to try to find common ground on that issue. Could you give a sense of what that's like and the challenges, but where you've had some success?
Certainly, and thank you to my panelists and Josh for having us up here. I think the discussion is very important. I think throughout the morning, we've talked a lot about the science. I like to focus on the art of public health because they have to go hand in hand. And one of the first steps that I've found, being local health officer for about 6 years in West Virginia and then state health officer for about 4 years, is the first step that I felt that has been helpful to be able to do things that we've been able to do is to build trust and credibility within the communities that we're attempting to serve. That trust and credibility is based in science and data, but it has to happen with a lot of the colleagues across, so it's both internal as well as out-facing with the public. And the basis and the foundation for that really is in accountability, transparency, and an approach that we're very used to in public health, I think, in basically using the mic to tell people what to do, but we have tried to use the idea of showing the mirror. And I use that analogy to answer the question about opioids. One of the first things we did back last fall is, because we were number one in opioid overdose deaths or overdose deaths overall in the country, not only were we highest, but we were like 33% higher than the next state. So challenge was really to understand those individuals first. So we did what we now call social autopsy, and we're working with several states now to conduct that, which is look at individuals who've died because of it, everyone, but in a sort of a CSI manner, figure out not just the medical causes or the drugs associated, but were they employed? Were they educated, and how far? Did they have health insurance? Were they a widow or single or married at the time? So all of these social factors that go around individuals, the whole individual, try to understand each and every individual's life, develop themes, and then you're very happy and really lucky to have Hopkins' team help us conduct a process to develop an opioid response plan in which we opened it up to the public. We asked them to comment, and we received almost 500 comments online, standing room only meeting. That so glad that Josh was able to. I don't know how it's again art how to manage a tough meeting with all facets and all opinions. And then we put all of those comments back online for people to view, de-identified, of course, and develop policy and laws changed because of that in a matter of months. But the bottom line here is transparency, accountability, and a data-driven approach.
Thank you. Dr. Whelan, you have been involved in a lot of payment reform, both at the Innovation Center and now at Medicaid. And it's struck many people that while there's so much argument about, say, Medicaid expansion or the Affordable Care Act, on payment reform, there's been a pretty impressive amount of bipartisan support, and anyone who goes to the website can see that there are a number of states, red and blue, that have engaged in payment reform. Where does that common ground come from your perspective, and what do you think we can learn from that?
So I'm here representing the medicalization of population. As my role as Chief Population Health Officer, we do look at that range of population health management, which is a lot of what the healthcare industry is focusing on. But as Josh pointed out, there's more and more, and it's been really exciting for me to see more and more activities looking towards what Dr. Kindig and others have described as a different kind of a population health approach. And I think, and I've been doing this now, I've been CMS in both administrations and worked in what got me into policy in the first place was working in a community center in West Philadelphia and trying to get healthcare started and thinking the incentives are just wrong. And never did I think I'd be working at CMS, but it was that wrong incentives that got me to this place. And I think the agreement is there's certain things regardless that we all agree fee-for-service is broken. Fee-for-service is getting the outcomes we're paying for, and that's not creating a healthier population. The second is we've got limited resources. That pie of money is not going to get bigger, so we have to do a better job maximizing the resources that we have in front of us. And third, we know that we're spending all this money and we're not getting better outcomes. And that's a kind of a mutually agreed upon. No one, I don't think, can contest any of those issues. And what I've seen now, there's lots of different approaches that are not partisan. They range the political spectrum. When I first got to CMS, it was the startup of the Innovation Center, the Center for Medicare Medicaid Innovation, which was created as part of the Affordable Care Act. And that was a way of saying, we don't know what model works better than fee-for-service. We know fee-for-service broken, so what are the different models? We started with accountable care organizations and trying to look at having folks be more accountable for a population, an attributed population. Then in 2015, we saw Congress pass in a uniquely, almost surprising bipartisan approach, MACRA, the Quality Payment Program, which was a very deliberate attempt to move Medicaid Medicare away from fee-for-service to a payment model that improves quality cost effectively. And there's some really interesting kind of public health, population health aspects to what the MIPS program is, which I won't get into now if anyone hasn't had enough caffeine. And now with this administration, Secretary Azar has identified that one of his top 4 priorities is value-based health care and looking to make sure that we do a better job paying for outcomes. And so I think that we've seen an array of approaches, and I can get into them later as we start to talk about it, but we've seen specific approaches in each one of those areas that I think, while medicalization is not the solution, and I am a hiker, I'm not sure the hiking analogy might work, but I think we need to expect healthcare to do everything that it can do without encroaching on other areas that do it better. But when you're dealing with the healthcare delivery system, how do we maximize everything they should be doing? We now see that when the accountable health communities, ACOs first started, I was at the Innovation Center and we heard some of these entities saying, you know what, we're looking to pay for a microwave so that someone doesn't go into long-term care settings. Someone was surprised that they were thinking about an air conditioning for asthmatics. And now we're seeing, just Forbes magazine 2 weeks ago had an article about how the big health payers are spending hundreds of millions of dollars on rent because they realize you can't get to the outcomes you're looking for unless you do that kind of an investment. So we're not owning it, medicalization, but I think we need to do a better job maximizing it and helping to clear that path and make it stronger.
Great. I want to talk about the audiences for this conversation, and maybe first with healthcare, building off your point, but then I want to go beyond healthcare. And so, just reflecting on what Ellen Marie was talking about, how have the conversations gone in West Virginia and Detroit with getting healthcare organizations, not just to maybe screen for whether people are getting benefits that they are due, which is not a bad thing, but to really enlist them as partners in what we would all agree would be fundamental population health efforts?
I can give an example of something we've done in Detroit and just launched, actually. So we have an unintended teen pregnancy challenge in the city of Detroit. A teen in Detroit is 2.5 times as likely to get pregnant than a teen across the rest of the state. So instead of, as a health department, I could have just said, okay, I'm just going to go launch a campaign, and I'm going to open up a clinic and just start doing things, providing contraception. We kind of did that, but what we did first, actually over 2 years, was actually engage every single long-acting reversible contraceptive provider in the city. looked at Medicaid data and actually brought them all to the table and said, okay, what population do you serve? What are your challenges? What hours do you operate under? Which LARCs do you provide and which ones do you not have access to? We found out that some of them only see certain types of insurances, and so when a person comes in and they don't have a particular insurance, they send them away and don't know what to do with them. So what we did at the health department was say, okay, how about we bring you all together? And we've created a network of providers. We created a hotline. There's a campaign, we can get into it later on, about how you really engage the community. But we have a health department clinic that's open after hours and weekends. We have brought together all of the resources so that the community understands what's available, and we've provided the transportation. There's a huge issue of transportation in the city of Detroit because it's so geographically vast, but it lacks a robust transportation system. So we're providing Lyft rides, we're providing the education, and we're providing the after-hours support, and we see all comers regardless of your insurance status. So again, it's thinking about the entire ecosystem and filling those gaps where it's needed.
So, I think it's very important for us. We've talked about a lot of process. Again, I think it's the result-oriented process is important. Some of us get stuck in the process, and we want that to be perfect and have a high level of integrity, which no doubt we do. But what we've tried to do is work with goals in mind so we can actually achieve outcomes. I'll give you an example. When I joined in 2015, my state position, our smoking in pregnancy. So smoking rate is a problem in Appalachia. But more specifically, in addressing that historically, the question we asked is, where can we impact? And amongst the vulnerable population was smoking in pregnancy. I think it's uncontested that that's perhaps one of the most important populations. Smoking pregnancy rate was about 29% in West Virginia, as opposed to about 8-9% nationally. When we looked at the Medicaid population, it was about 42%. And if you really look at some of the coal mines in southern West Virginia, it was about 49%. So 1 out of 2 pregnant women in West Virginia in a certain population was smoking. So we started a program called MOMS, Management of Maternal Smoking, that actually brought in federal, state, local stakeholders together that included not just educating and training OBGYN, connecting folks with the quit line, screening universally women, also having a text-to-mom program where women will be reminded of that, and working with our Medicaid partners in evaluating some of their policies that they had in place at the time for payment and others. And recently we've seen in PRAM's data almost a 25% reduction. It's a historic first-time reduction from about 29 to about 22% and change. It's those kind of things that takes stakeholders, partners, patients, providers, but I think it's also important that we've got to have goal in mind, what we want to achieve, and then be able to document that in a way that will impact future generations to come. These are often areas which, if they have proper support and data evidence behind it and a push, we will have long and lasting impact for future.
Yeah, let me push a little harder on healthcare, though. I think we want healthcare providers to provide high-quality healthcare. Number 2, maybe they're doing some individual interventions that are good for overall health. Number 3, they're collaborating with the Detroit Health Department, the West Virginia Health Department on these overall efforts, whether it's teen pregnancy or smoking. But, we think of population health as involving a lot more than that. And I wonder, Ellen Marie, as you're thinking about the fundamental incentives, is there hope out there, or what can Medicaid programs do? How do we align incentives in a way that healthcare could be fundamentally, more engaged with discussions of, say, employment or environmental conditions or access to food or some of the things that are some of the, more underlying structural issues?
2 of the new models that are, one is underway and one has just been announced and not started at the Innovation Center, are specifically looking how to bridge the community and the clinical piece and figuring out what is the best approach that we at CMS can have The good thing about the Innovation Center models is every one of them by law needs to be rigorously evaluated. And so with states having a paucity of resources and trying to figure out how to use those healthcare dollars spent best, once these models are going through and we can figure out with the data of what works and what isn't working, we're hopeful that other states will be able to adopt them. So the first is the Accountable Health Communities, which is funding bridge organizations to provide social health issues. That we have to figure out how we word that, but helping to pay for these bridge organizations in the communities to either just to refer to some of the social community agencies, or really aligning really closely with them and being able to then document and test these with the data that we have to understand what impact they have. A new model that was just announced, the integrated model for children, is looking at how we have a partnership between lead organizations in the community and the state Medicaid agency to look at doing the same thing. How can we support this collaboration? And ultimately, in both models, we're hoping that by doing some of this, being able to look at supporting some of the upstream efforts, we'll be able to ultimately look at some of the longer-term health outcomes. And then we also see we see that there are models at the Innovation Center. We see states doing very similar things too. We've got 4 or 5 states that are doing their own accountable communities of health, figuring out what that means for the local organizations and acknowledging how flexible Medicaid is. There's lots of things Medicaid can do that states are not yet opting to do, and these states are being really creative about how to do that.
So that may be an opportunity.
One last thing is too, and I think it's been measured, and I think it's spoken before, is what we're measuring really matters. And we've been interested to, and there is no agreement, and that's work that we need to continue to do. But some of the states are looking at things like school readiness or reading by 3rd grade, and that's a really exciting metric to be looking at. If a state Medicaid agency is wanting to have that be what their providers are looking at, that could do wonders for the required integration that needs to happen in order to improve some of those kinds of metrics.
That's great. That gives me a chance to plug the last meeting of the Population Health Roundtable, which was about how the health sector can improve education outcomes, and is all online. So I want to go broader than healthcare here. As you're thinking about this work practically, how do you communicate outside the health sector to businesses? The Surgeon General is doing a big report on the economy and business. How have those discussions gone? And I don't just mean like the successes, like what are the challenges? This gets a little bit to what Professor Williams was talking about with empathy. How do you get people to see the kinds of problems that you're dealing with as problems that need to be solved? Go ahead, Rahul, and then Dr. Khaldun.
I think it's part of it's having an agenda that's data-driven and what you want to get out. The other part is understanding the community that you're dealing with and stakeholders. I'll give you an example. One of the reasons I actually came into West Virginia was we were having a very controversial clean indoor air regulations, which is basically smoke-free areas, restaurants, and one of the first things that we need to listen a lot more than talk. And so one of the first things listening to, we discovered what the root causes are for people who own businesses to be resisting those kinds of policies. And once we put the fix in to help them, we had a really great embrace across the community for clean indoor air policies in West Virginia. So, and again, we've demonstrated with some data published that the impact of that, as opposed to even statins on cardiac disease, and we've seen a demonstrated reduction in admissions for acute coronary events in the Valley area over the years. So there are good policies, but I think the art really is being able to drive that to the community stakeholders and be able to convince them, as well as being able to understand the needs and demands of the community. And again, that's where the divide, being able to be bridge makers in order to narrow that divide that often exists. We can no longer afford to exist in a vacuum as a public health agency.
Khaldun.
I would agree with that. I think, one of the things I always say is you don't need a degree or to have some type of title to know what's best for a community. And I think one thing we need to really work on in public health and across other sectors as well is really genuinely engaging the community in the work that we're doing. It's not about, we've got this perfect data, it's evidence-based, let me just go plop my program down in your neighborhood, and then we wonder why it fails, right? I think we really need to slow down and genuinely listen to the people in a community. And they may not have the evidence, they may not be as articulate, they may not have a degree, but really understanding what their challenges are and what they need, I think that's how we'll be able to move the needle a little better. The other thing I wanted to bring up is often what I see when my public health colleagues go into a room with non-public health people is we start talking about, social determinants and primary prevention and, upstream. People don't understand what that means by and large. You have to speak the language of the stakeholders that you're engaging with and have very real, tangible benefits that you're trying to discuss and encourage them to come on board with. So it's not social determinants of health. It's, no, I'm going to get someone a ride so that you'll be able to save money for your business, so they'll come to work. But one thing where I've seen my population health colleagues fail and where we need to improve is in that communication across stakeholders.
Great. Well, I've got one more question, then we'll go to questions, so start to think about them. I want to build on that point for your population health colleagues, since we have a lot of them in the room and watching online. Given the importance of the engagement that you're doing, the difficulty, the challenges there, what could be helpful out of the field of population health? Is it evidence? Is it understanding a process? What would you like to see the academic field do more of to provide, more support for the very difficult work that you're doing?
I think, one, listening to the community, but also recognizing that, unfortunately, there are politics in everything. Often when I get students in the health department who just came out of their public health school, they say, well, this is the evidence, and I've got this long paper, and I'm just going to write it, and I can't believe that they're not going to do this, because you have to think about your stakeholders and who you're speaking to. I really think as public health educators, we really need to work with our students and help them understand politics, policy, how it's made, how to engage with policymakers. It's not your big, whatever regression curves. No one wants to hear about that. They want to hear about real stories, real outcomes, and how it's going to benefit them. And I think we need to do a better job of being able to sell our story in public health, speaking others' language.
And I agree with that. I think it's actually having our academic partners in population health understand the needs that exist and actually the research gap that exists rather than worried about a particular agenda item. So I think some of that is, there's a tremendous amount of need right now within the opioid realm, for example. There's some evidence, there's not a lot of evidence, and there's research that needs to happen. But so understanding actually and having the community and the needs of those communities inform the scientific inquiry, which helps us then drive policy, is critical. And understanding sometimes we win and sometimes we lose. A very quick example is, in the previous administration where I was, the governor was from a different political party, and I was asked to come and provide evidence on what we should do about mountaintop removal mining, and because there was a press push for it. And I recommended that we approach the federal agencies to ask for a study. And this was a very pro-coal governor, was able to make the case, and we did. We moved forward, and we made requests, and we were successful in getting the funding to the National Academies to research that, and then that was terminated earlier last year. And that's okay. I mean, it's the effort, I think, that's critical in making the effort to find those research gaps and then pushing to apply science where it doesn't exist. And sometimes it'll happen, and sometimes it may not happen.
I would also say, I guess right off the bat, is don't give up on us. I think find opportunities to partner with the healthcare delivery system. We've been trying to do that more internally in-house by reaching out and working with our colleagues at HRSA and CDC And one example, I'll give a shout out to John Auerbach when he was at CDC, is one of the projects that we've been working really closely with CDC is identifying 6 different areas, 6 different conditions where we knew that there was evidence-based interventions that could help move the needle on helping to prevent or improve the care that was given there. And we work closely with CDC and Medicaid to bring states together and bring their public health and their healthcare community, the Medicaid agencies together to figure out what was standing in the way of these activities. For the most part were reimbursable. They weren't happening. What was standing in the way? And by having these conversations with the public health and the healthcare community and the payers, we've seen some really exciting advancements in not only what we started out looking at, but some other areas that kind of have burgeoned just because those conversations are going on. So don't give up. Help us find opportunities to work together.
Great. When we go to questions, while I look over here at Carla to tell me how many minutes we have left. We're good? Okay, go ahead, Terry.